Good afternoon. I am Anastasia Robin with the QCDR and Qualified Registry Support Team. We're also known as the Practice Improvement and Quality Measure Management Support Team, so you may have heard of that. But we do want to thank you for joining today's 2026 QCDR Measure Development webinar. With that, I will now turn the call over to John Jenkins, who's one of our co-leads for the QCDR and Qualified Registry work. John?
Well, depending on where you are, good morning or good afternoon. Around here, it's good afternoon. We're glad to see you guys could make it today, and we're going to have hopefully a very productive meeting. Next slide, please. They tell me I have to read this. I don't know why. It's kind of like being in, kindergarten, having to read in front of everybody, word for word. So this presentation was prepared as a tool to assist providers, and it is not intended to grant rights or impose obligations. Although every reasonable effort has been made to assure the accuracy of the information within these pages, the ultimate responsibility for correct submission of claims and response to any remittance advice lies with the provider of services. This publication is a general summary that explains certain aspects of the Medicare program, but not a legal document. The official Medicare program provisions are contained in the relevant laws, regulations, and rulings. Medicare policy changes frequently, and links to the source documents have been provided within the document for your reference. The Centers for Medicare and Medicaid Services, employees, agents, and staff make no representation, warranty, or guarantee that this compilation of Medicare information is error-free and will bear no responsibility or liability for the results or consequences of the use of this guide. Just to keep in mind, when anything goes out publicly from the government, it's always best to ensure that you follow any written guidance that's put out there. That's what we have to rely on. Next slide, please. So what are we going to do today? We are going to talk about, obviously, the overview and requirements for measures, QCDR measure basics and development. So what do you do to develop a new measure? What's expected? We're going to give you some best practice review and tips for successful submission. We're going to talk about measure testing. We'll look ahead for the transition between MIPS and the MIPS value pathway. And then we'll provide some resources and a question and answer section. Next slide, please. And on that, I would like to hand this over to Dr. Michelle Schreiber.
Thanks, John. I appreciate it. And good afternoon, or if you're on the West Coast, I suppose it's still morning. Thank you for joining us today on the QCDR call. And hopefully we will be providing interesting and important information for those of you who participate. I do want to acknowledge that putting together quality measurement is not for the faint of heart. It is a lot of work. And we appreciate all of the efforts that you have done in developing quality measures, in making them available, and in working on really the best and most impactful measures, especially for your particular societies or specialties that you may serve. I want to highlight again the transition to MIPS value pathways and the importance that is for CMS, because it really allows for meaningful specialty measures that are limited in number and choice. So rather than just choosing from the 200 MIPS measures that are there, we recognize this is a smaller choice, but those specific measures are meant to be most meaningful to those specialties or that disease state. And they are also then linked and aligned with cost measures, with improvement activities, and then promoting interoperability as something for all. And so this curated list that is aligned across components of the MIPS program is what makes up the MIPS value pathways. I do want to note that there has been work to transition measures to FHIR. Most of you have been hearing this now for a number of years, but I'm very excited to say that it seems like there's some light at the end of the tunnel that is starting to appear. CMS is working diligently to build their FHIR servers. We have already specified our electronic clinical quality measures for fire. NCQA has specified many of their HEDIS measures, for example, for fire. And I just want to say that all of us, I think, can expect at some point in the future, and again, I don't know when that point is, but it's getting closer every day. At some point in the future, we will be looking for measures to be digital and fire specified. With that, we are happy to answer questions, provide information. I do want to remind you that there are pathways for putting your QRDA, your QCDR measures. Sorry, I can talk about fire. I think of QRDA. Your QCD measures into the MIPS program. And we may be talking about pathways for doing that. But I just want to close by saying thank you for your commitment to quality measurement. And thank you for the work that you do for the registries. And I will pass this back to our program leads.
Thank you very much, Dr. Schreiber. Again, thank you for joining us today. This is Stacy Sams, and I'm with the Pickens team. And I'm going to be kicking off just the first part of today's presentation, and we'll be passing it on to other members of our team. I'll just start by taking a glance at the QCDR measure timeline and wrap up sharing some hopefully helpful tips to consider when you self-nominate QCDR measures for CMS's review before I pass it on to Marla with the Pickens team. So we'll go ahead and jump on in. Next slide, please. So this slide shows a high-level overview of the QCDR measure processes that take place throughout the performance year. It begins with measure development, which is a continuous process where QCDRs are creating and possibly collaborating with other QCDRs to create QCDR measures that potentially end up being approved for use in MIPS. And once a QCDR considers their measure to be fully developed and ready for implementation, the measures must be submitted by the QCDR with their self-nomination form to help guide QCDRs as they prepare for the self-nomination process. There's a resource that gets published on the QPP resource library called the Self-Nomination Toolkit. And this is a toolkit where you'll find guidance on measure development and also details on how to self-nominate your QCDR measures. It also includes a user guide that would help you step-by-step when submitting the measures in your self-nomination form. The annual self-nomination period opens on July 1st and closes on September 1st. And depending on the day of the week that these dates fall on, that could vary slightly by a day or two, just to avoid weekends and holidays. But during that time, each QCDR's self-nomination form will be reviewed, and CMS will determine if the QCDR meets requirements and is eligible to submit QCDR measures on behalf of MIPS eligible clinicians. And if they are approved and they submit QCDR measures, only the measures that they submit during the self-nomination timeframe will be reviewed for CMS for potential inclusion in MIPS. Any QCDR measures that are submitted outside of this timeframe are not considered. And once that self-nomination period closes, each QCDR measure that was submitted will undergo a detailed CMS review to determine whether to approve or reject the measure. Even rejected measures go through an additional level of review with CMS leadership before decisions are finalized. Once we do finalize all the measure decisions, we communicate that to the QCDRs, and QCDRs are then given an opportunity to appeal against any rejected measures through a process we call the reconsideration calls. These calls are meetings, and they must be requested by the QCDR, and they're held between the QCDR, CMS, and members of the Pickens team, just offering an opportunity for you to provide rationale why the rejection should be overturned and the measure should be approved. So once we finish up the reconsideration calls and finalize the measure decisions, we'll work closely with each QCDR to ensure that all the approved specifications are in their final state. And once they're finalized, they will be published to the QPP resource library. And then finally, once those approved measures are published, QCDRs will be given a 15-day window to also post your specifications on your own website and provide the link. And a reminder that these specifications must remain posted through the performance period for which they're approved and the corresponding submission period. Next slide, please. So during the measure review process, CMS takes into consideration many different requirements to help ensure that all QCDR measures are meeting the same standards should they be implemented in MIPS. And one goal is to ensure that all measures have progressed beyond the concept phase of development and would be ready for implementation. Part of this is meeting the measure testing requirements. Marla will be discussing testing in more detail later in the presentation, but at a high level, new measures being submitted for the first time only require face validity, and after the first year in MIPS, the measure must be fully tested and developed. Measures are also expected to address clinical areas where there's evidence that a gap in performance exists and that the performance shows some meaningful variation. You will be required to submit performance data with your self-nomination form. Measures should also prioritize outcome-based concepts over process-based. And finally, a repeating trend that you will likely hear today are measures that are duplicative to either a retired or current QCDR or MIPS quality measure. We encourage you to complete a thorough environmental scan before you submit new measures, just to ensure that the measure's concept is not already addressed in another measure. Next slide, please. Thank you. Every QCDR measure that you would like CMS to review and consider must be submitted during the self-nomination period, and will go through the approval process, regardless if the measure was approved the prior performance period. This will just ensure that measures still address gaps in care, continue to be meaningful, and still align with clinical guidelines and recommendations. In addition, when a QCDR measure is approved for a specific performance period, it is expected that the QCDR is up and running and able to collect all the measure data and implement the measure by January 1st of that applicable performance period for which it's approved. Next slide, please. So measure posting. As I previously mentioned, there are additional requirements that must be met for QCDR measure to be approved and implemented in MIPS. We work directly with each QCDR in your self-nomination form to ensure that specifications are complete and accurate before they're publicly posted. They must be available throughout the duration of the measure's use, so those who are reporting the measure can clearly understand the target population and how the measure is built and to be calculated and reported. When specifications are finalized for all of the approved measures, they again are published to the QPP resource library, and the QCDRs are given the 15-day window to also post them and provide a link. And once the link is provided, we will follow up with each QCDR to confirm that at a minimum, the required specifications are included in the posting. And another friendly reminder that they must remain posted beyond the performance period and throughout the submission period for which it's approved. Next slide, please. So last, when you self-nominate a QCDR measure, we ask you to link that measure to at least one cost measure, improvement activity, or MVP. As MVPs are continually being developed, it is helpful to correlate QCDR measures to other performance categories, and it can just help with the development of more robust and cohesive MVPs. And if a QCDR measure does not have a clear link to a cost measure, improvement activity, or an MVP, CMS would consider exceptions if the measure meets all other requirements and considerations, and all that information should be submitted with your self-nomination form. And one example would be if a particular specialty that the QCDR measure applies to is not currently reflected in the cost measure or MVP inventory. Next slide, please. So now we'll move into some QCDR measure basics and provide some additional guidance on measure development. So QCDR measure basics. During CMS's review of the QCDR measures, there are several considerations that are taken into account, and we will cover most of those on the next few slides. CMS looks for measures that are meaningful and will push the needle to improve quality of care. They should be evidence-based and align with current clinical guidelines and recommendations. Preference is for measures that require the completion of a meaningful quality action over process-based measures that only require checking off a box that an assessment or a screening was completed. We do encourage you to take that assessment or screening one step further to include an intervention or quality action that just helps ensure that any issues that are identified by the assessment or the screening are being addressed, and not just that the assessment or screening was completed. Another repeating theme is duplication. Preference is for measures that do not address concepts that are already captured in the current or retired measure inventory, and that's QCDR or the MIPS measures. And finally, the measures performance data should show that a gap in care exists and that there's variation among clinicians. Measures should have the ability to show evidence that there's room for meaningful improvement, as high-performing measures with little room for improvement can lead to that measure topping out quickly. For newer measures, there may not always be a full year of data, and in these situations, we just request that you submit any partial data that you may have, anything that can show evidence of a gap. And when performance data is not available to any degree, CMS may consider current cited clinical guidelines or recommendations from a reputable source, and preferably within the last 5 years. Next slide, please. So every self-nomination, we receive a few hundred QCDR measures for CMS to review. Year over year, we do notice common trends that pop up where we find ourselves repeating the same feedback. So we'd like to walk through some of the typical scenarios that we see. The first one's probably the most common that we see year over year. They're measures that do not focus on a quality action or an outcome. And we often receive measures that only capture the completion of an assessment or survey, or a checkbox measure, as we commonly call it. It doesn't mean that those processes are not clinically important. It's just hard to identify how they're really pushing the needle and improving the quality of care that patients are receiving. The preference is for measures that take the patient care one step further and require follow-up plan or some type of intervention. And this can also help ensure that abnormal and unusual findings from the assessment or the screening are being addressed and taken into consideration. Additional preferred outcome type measures are intermediate outcome and patient-reported outcome measure types. And another consideration are measures that represent a clinical process, but they're split out into separate measures. To make it more meaningful, we prefer that there's one more comprehensive measure instead of having that one concept broken into several individual measures. An example of this could be 3 lab testing measures where their combined results are necessary to manage a specific condition. But in this case, each lab test is separated into its own individual measure. So you would likely receive feedback to combine those types of measures. And again, this last piece, mentioning again, because it's something we see consistently, are measures that are similar to either a retired or current QCDR or MIPS measure. Preference is for QCDRs to collaborate among each other, and if there's existing measures, to make updates to that measure so it covers the broader population or clinical setting. Next slide, please. As previously mentioned, preferences for measures that show a variance in performance between clinicians. A measure's performance data that shows variability in the clinician's performance is more meaningful than a measure in which all clinicians are consistently performing 95% or higher. This does speak to measures that focus on events that happen very infrequently, that it's not meaningful, or so-called never events, such as a fire in the operating room. There's just such a very small percentage difference between the top and bottom performers that there's no variability, and it's hard really to distinguish that one clinician is actually doing better than another clinician. The next in the list is reducing clinician burden and having measures that do not impose extra burden on clinicians to report by leveraging the use of existing coding systems or choosing the appropriate collection type are just a couple of ways that that burden can be reduced. And to ensure that clinicians can effectively capture the correct patient population for a measure, we request that you further evaluate if there's a need for denominator exclusions or exceptions, as those can help reduce the potential for unintended consequences and also avoid instances when the quality action may not apply to every patient that's falling into the denominator population. And last, another trend that we see are measures that are measuring care that should be routinely expected or performed consistently. And one example is obtaining patient consent prior to surgery. Patients signing consent prior to surgery should be considered standard. And so these types of measures should be further assessed for ways to incorporate more of a quality action. Next slide, please. So once again, avoiding duplicative concepts is near the top of the considerations when reviewing measures. Prefer for duplicative concepts to be combined into a more comprehensive measure. This can help allow for better comparisons among a larger group of clinicians and can also help reduce clinician burden because they won't have to choose a measure applicable to them over several that are available. And to help identify similar concepts when you're developing QCDR measures, we encourage you to complete a thorough review of retired and current inventory and take those available concepts into consideration before self-nominating your measure. Next slide, please. Expanding just a little bit more on the measure concept duplication, this slide shows 3 possible situations that, and this feedback you may receive when duplicative measures are submitted between two active QCDRs, the suggestion would likely be for one of the QCDRs to obtain permission from the other QCDR to borrow their existing measure. There are certain circumstances where duplicative concepts may be approved for one performance period under the condition that QCDRs do work to address and resolve the duplication before the next self-nomination period. And when this is not resolved, we're tasked with having to pick the most robust of the duplicative measures. And we would really prefer that this is resolved between the QCDRs. And last, if the duplication is between a QCDR measure and a current MIPS quality measure, oftentimes the preference would be for the MIPS quality measure, as those measures are more broadly available and not restricted to only the use by QCDR. Next slide. Finally, here are a few of preferred measure types. Again, outcome-based measures are preferred over process-based measures. And those outcomes focus on the health status of the patient resulting from the care they received and may either be a desirable or an adverse result. And one type of outcome-based is the patient-reported outcome performance measure, which does require information reported directly from the patient. And that data is collected using a PROM tool. And with these measures, the tools should be standardized, validated, non-proprietary, and broadly available. And that's something that will be taken into consideration as well. And the last outcome type, intermediate outcome, those look at changes that result from an intervention that leads to a long-term outcome, where the intermediate outcome actually leads to a desired outcome. And last is patient experience. These measures center around the patient's voice and encourage the patient's input when planning their care. And these measures may also help to improve family and caregiver experience as well. Next slide, please. So I'll now turn it over to Marla Throckmorton with the Pickens team, who will continue to provide some guidance and tips for submitting your QCDR measures. Marla?
Thanks, Stacy. So let's start talking about the QCDR measure review and tips for a successful submission. So when you are submitting your QCDR measure specifications using that QPP self-nomination form, please review and submit all required specification components in their entirety. These are for both owned and borrowed measures. If you've self-nominated before, you'll know that the owned measure has a much larger or number of fields that have to be completely filled out. Whereas if you're just borrowing the measure, it's only a few fields that have to be filled out for those borrowers. Remember that the most important pieces for CMS to assist in their reviewing as far as requirements are testing data, performance data, measure recommendations, and then the rationale for that measure. Make sure you complete a good spelling and grammar check. Substantive revisions are not allowed after self-nomination closes. These revisions, any revisions, will be limited to minor edits such as grammar, punctuation, etc. Please remember that QCDR measures cannot be added to your measure portfolio after the self-nomination closes. Only MIPS quality measures can be added. The self-nomination usually closes around that September 1 timeframe, and then that MIPS quality measures, I think that timeframe is usually extended into the spring sometime the next year. Please remember to check your QPP self-nomination form often to make sure that you are compliant with the timelines and requirements that are due. Our Pickens team works really hard to send you notices of all the action items that are needed. And then we do try to send reminders on a routine basis just to help you stay compliant. And then also, if you are going to support a measure that is in an MVP, that measure must be self-nominated at the time of self-nomination, and you also must have permission. If you're not the owning QCDR of that measure in the MVP, then you are trying to borrow it, and you do have to include that written permission from the owning QCDR, as with all borrowed measures. Next slide, please. Now let's talk about multiple strata and multiple performance rate measures. What's important to note, and why we're bringing these types of measures up, is that the distinction is that these things are what is required for CMS to be able to know what is being submitted, and then what is the calculation of the rates, and whose responsibility that is. So for collection and submission of data for multiple populations and or quality actions, these are referred to as multi-performance rate measures. A multi-strata measure is each denominator population or quality action or numerator represents its own strata or subcomponent. And then a multi-performance rate measure is that all strata and performance rates are required for submission and reporting to CMS. On a multiple performance rate measure, data is not aggregated prior to submission to CMS. QCDR should carefully review their specifications to identify if there are multiple strata and or multiple performance rates, and which performance rates are going to then be used for reporting and benchmarking. Next slide, please. This slide just is a graphic to help you see the different components of what we're talking about. This first column indicates how many performance rates should be submitted to CMS for reporting. And these are also the fields that are in our measure specification files that you receive after self-nomination, after that self-nomination closes, as we go through that approval process. So that first column is the number of performance rates to be calculated and submitted. The second column is performance rate descriptions, which outlines the different strata or denominators needed for QCDR, internal data aggregation, or performance rates submitted to CMS for reporting. And then finally, the last column indicates an overall performance rate. In this example, one performance rate, of course, is going to be the first performance rate that is required. But as you see here, there are 3 strata. And then let's say the first column was 3. You have 3 performance rates in the middle column. Then you would have to choose the first, second, or third performance rate. Then that would be considered the overall performance rate. Next slide, please. Here is an example of a multiple performance rate measure that utilizes a specific stratum for the overall performance rate. This requires submission of multiple performance rates to CMS. What the QCDR must do prior to submitting the data is to identify the performance rates required for submission. In this instance, there are 2. And then you identify the performance rate that will be utilized for benchmarking. In this example, the overall performance rate will be numerator criteria number 2. The QCDR then must calculate and submit data for 2 performance rates to CMS. So you said you're turning in 2 performance rates. You're going to calculate those and submit those. And then once you give those to CMS, you're telling CMS that they will select the second performance rate for the scoring and benchmark. What CMS does after they receive submission of the data, they'll collect all the data for both performance rates, and then they'll use performance rate data to rate 2 data to create that benchmark. Next slide, please. Now, this is an example of a multi-strata measure with only 1 performance rate for submission and benchmarking. What the QCDR has to complete prior to submission of the data is to identify the performance rate required for submission and benchmarking. So they're saying there's only 1 performance rate there in the first column. And of course, first performance rate would have to be the overall performance rate. You would have to calculate the multiple strata and aggregate into 1 overall performance rate, which is the one you would then submit to CMS. But as you can see here in this example, there are multi-strata, and the QCDR can still collect data on the different strata, but then only submit the overall performance rate to CMS. And why this can be a great strategy is that the QCDR can use this information to inform their clinicians on possibly the strata that they're not performing well on, so then they can focus on an area to improve. So let's say that a clinician does really well with male patients as in numerator criteria 1, but they don't do so well for the female patients in criteria 2. And then that way you can go back to the clinician and say, hey, you might need to focus on this. This is where your gap is, and this is where your area for improvement is for that overall performance rate. Again, CMS, I'm sorry. Okay. Then what CMS will do is collect data for that one performance rate that you've told them, and they'll utilize that to create the benchmark. All right, next slide, please. Our last example is about a multi-performance rate measure where CMS calculates the performance rate. This is the simple or weighted average for the overall performance rate. This requires submission of multiple performance rates. It is what the QCR must complete prior to submission is they need to identify the performance rates needed. In this example, there are 2. But please note there must be at least 2 or more performance rates in order to calculate either a simple or a weighted average. Weighted average is the sum of numerator values divided by the sum of denominator values, whereas a simple average is the sum of performance rates divided by the number of performance rates. And so the QCDR must submit data for 2 performance rates to CMS. And then what CMS will do after they receive the data, they'll collect that data for both performance rates and then calculate a simple average in this example, or it could be a weighted average. And then they'll use that simple average result to create the benchmark and scoring. Next slide, please. Let's talk about ownership and eligibility of QCDR measures. A QCDR measure must be owned or co-owned by an approved QCDR. And what we mean by an approved QCDR is that they have gone through the self-nomination process. They meet all the requirements to become an approved QCDR, and they are approved. They haven't had any compliance issues in the past. There's nothing holding them back from continuing to be an approved QCDR in the program. That approved QCDR must be active within METS. And the reason this is important is because if a QCDR is no longer participating, but they have a very meaningful measure that is used by multiple QCDRs, that way that QCDR measure can stay in the program once it is taken over by an approved active QCDR. The inactive QCDR may transfer measure ownership rights to that active MIPS approved QCDR. The new owner must be able to continue to support the measure for the MIPS performance period. They have to be able to provide medical and measure expertise to be able to manage the measure. Again, that's evidenced by being an approved QCDR. And then that new owner can also permit other QCDRs to use the measure. A permission to be the owner or the transfer of ownership must be submitted and granted at time of self-nomination of the measure. Next slide, please. Measure adoption. If a measure has not met the benchmarking thresholds, meaning they haven't met the case minimum and volume for 2 consecutive performance periods, then CMS encouraged the development of a participation plan as soon as that measure shows low adoption. And what a participation plan's goal is to come up with a plan to increase adoption of the measure, but also it not only do you have to plan it, but you also need to implement that plan into place so that you can actually see that adoption occurring. Things that can be put in those plans are things such as education and a communication plan for clinicians, educating them on a measure, making sure they know how it works, how to implement it easier, those types of things. QCDR might require a clinician to report on the measure as a way of staying viable within the QCDR. QCDR may encourage submission of the data for MIPS purposes. Oftentimes, QCDRs can collect data that's not been submitted on into the MIPS program, but really encourage the clinicians to submit to the MIPS part, because that's where the benchmark and adoption is proven for the measures. And then update a measure specification to encourage broader participation for that measure. Next slide. New measure IDs. So all measure IDs, QCDR measure IDs, are systematically assigned by CMS. Of course, if it's a new measure and it's not been in the program before, it's going to get its first time measure ID assigned. But for existing measures that may have changes, reasons they might have changes, as you'll see down there on that third bullet, is they might change the analytic of the measure, such as inverse to not inverse. They might go from a proportional measure to a ratio measure. They might add a risk adjustment. The numerator might be changed by adding a second quality action. There might be two existing measures that have a similar population. They're combined to create a new measure. And so instead of keeping one of the old existing measure IDs, they are assigned a new measure ID. And so anytime a new measure ID is assigned, the old measure ID is retired, which means that this new measure, the measure with the new measure ID, will be considered a new measure. And that first year that it's in the program with the new ID will be considered their first performance year. And then that also means that the measure can no longer be benchmarked against that previous measure ID of the previous version of that measure. Next slide, please. Now let's talk about QCDR and measure testing. Measure testing has been around for a couple of years now, and then we're really, the Pickham's team has really been excited to see how well this has been adapted and adopted by the QCDRs and meeting those requirements. As you know, a new QCDR must have a new QCDR measure must have a minimum of face validity prior to being self-nominated for the that first time that it's going to be proposed for the program. Once the measure becomes approved, now the second year that a measure ID and measure ID are in the program, then that measure must become fully developed and tested. The testing results must be done at a clinician level, and the testing has to be completed prior to submitting during the self-nomination process. To be a fully developed and tested measure, you have to have a countable entity level, which means measure score level, validity testing. You have to have measure score level reliability testing. You have to have patient or encounter level data element level reliability or validity testing. And we'll explain that a little bit more here in a moment, as well as feasibility testing. Next slide. The reason it's so important to do testing for these measures, and especially within the MIPS program, where there is comparison against other clinicians, is that testing and analysis is critical to development of a feasible, reliable, and valid measure. Testing has to be done during the measure development phase, alpha and beta testing, so that this really enables the developer to assess the strengths and weaknesses of a measure and be able to mitigate any weaknesses so that they have the best measure possible that shows clinical outcomes of patients. Testing assesses reliability, validity, feasibility, usability, and scientific acceptability. The goal is that it does reduce provider reporting burden by only allowing these really solid, fully tested and developed measures into the program, which is an iterative process which yields more accurate, consistent data for program scoring. Next slide, please. So the first type of testing to talk about is validity, the degree to which evidence, clinical judgment, and theory support interpretation of a measure's performance score for MIPS. different types of validity, face validity, which is a subjective assessment by experts. This is considered the minimal type of validity for that first year measure. It's the subjective assessment by experts based on experience about whether the measure reflects its intended assessment. The measure score level validity is then the next level of validity. These examples of this validity is convergent validity, which demonstrates measure performance associated with meaningful outcome or other indicators of processes related to the target outcome. Discriminant validity, where the measure can differentiate between disparate groups that are expected to perform better or worse than each other. And then predictive validity is another example of which is the measure performance can predict scores of other related measures or outcomes in the future. Again, as we said, new QCDR measures require only face validity. And then after that initial year of implementation, existing QCDR measures should be fully tested with this measure score level validity. Next slide. Reliability. This is saying that the data elements should produce the same results to the same phenomena time after time after time. This addresses the precision of measurement for the entity and to whom it applies. When there is a lack of reliability or precision, then this demonstrates that it's just random error and that there's no scientific way to be able to tell whether or not, one physician score is different from another physician score because of the clinical care they're providing. Instead, it might just be, just a random number that occurs. And so it's not a fair assessment of the clinician's outcomes. Different measures of reliability. The first one is signal to noise, which is the most common test, which this estimates the proportion of overall variability explained by the differences between entities. There's also temporal correlation, which assesses the correlation of data from adjacent time periods for each entity. And then also another example is random split half correlation. And this randomly splits data from each entity in half and then estimates the correlation of the two halves across all entities. Next slide, please. The first two we just talked about were that measure score level, right? And now this time we're talking about the patient encounter level data element testing. This level of data elements are the building blocks for a quality measure, and they should be assessed for either reliability or validity. This is required for meeting the definition of a fully developed measure. Testing may be empiric or reference external previous testing. Example of empirical testing is validity testing of data elements, such as criterion validity, which verifies data elements against reference criterion that have already been determined to be valid. Reliability testing of data elements ensures repeatability of testing findings. It can do inter-rater or intra-rater reliability in data abstractor studies. Internal consistency for multi-item test or surveys, or retest for survey items, which measures temporal reliability. Next slide, please. When you test using the reference to external or previous testing, you can use you can use resources such as an established data element library. Example of these libraries are the CMS data element library, or the DEL, the electronic clinical quality measure data element repository, or the DREP. Or of course, you can also use literature that has shown external or previous testing. Data elements that have already established as reliable, such as age, may be excluded from this level of testing for a QCDR measure. Next slide, please. And then the final type of testing that must be completed is feasibility. And this should be done very, very early in the measure development process. It occurs after you've identified which required data elements you need for measure calculation before you actually finalize that specification, because you have to make sure that the required data that you need is available and retrievable without undue burden. It's the extent data collection and processing that can occur without violation of patient confidentiality. It helps estimate the cost or burden of data calculation, data entry, and analysis. You want to see what the impact of collecting these data elements are on clinician workflow, diagnostic thought processes, and then also patient-physician interaction. It also helps identify unintended consequences, and also might find possible barriers that can eventually occur during implementation, data abstraction, measure calculation, and performance reporting. This also may support feasibility of data elements using systematic surveys. I'm sorry, let me rephrase that. Feasibility testing also can help support saying that a data element is feasible. You can use systematic surveys, or you can conduct focus groups to see if these are, common data elements that are used by your providers. Next slide, please. So that is what is needed to be a fully and tested QCDR measure. And now we're going to look ahead and transitioning to MVPs. I'll turn it over to Marlene Jones-Poole from the Pickens team for this next section.
Thanks, Marla. Hi, everyone. This is Marlene Jones-Poole from the Pickens team. Let's go ahead and look ahead into the CMS goals with a transition to MVP reporting. CMS has an overall goal of reducing clinician burden, and we did hear some of these priorities from Dr. Schreiber earlier in the presentation. First, we want to focus on measures that reduce the reporting burden, such as using administrative claims outcome measures and moving to digital quality measures, or DQMs. DQMs originate from sources of health information that are captured and can be transmitted electronically and via interoperable systems. Another goal is to reduce the quality measure inventory to ensure that it is meaningful by prioritizing outcome measures that are patient reported or assess the patient experience, and high priority measures. CMS also wants to align measures across programs where appropriate, particularly measures that are included in the Core Quality Measures Collaborative, or CQMC, and adding quality measures that can be implemented the same or very similarly across different programs. By aligning measures across programs, those clinicians who do participate in multiple programs will have a decreased burden, as they will not have to implement the same measure concept in multiple ways based upon the program. And again, emphasizing digital quality measurement, the goal is to integrate the data interoperability standard, Fast Healthcare Interoperability Resources, or FHIR data model. Next slide, please. CMS goals for MVP participation. QCDRs and qualified registries must support MVPs that are applicable to their participants on whose behalf they submit MIPS data. The goal is to move away from siloed reporting by offering connected measures and activities across the 4 MIPS performance categories. MVP reporting allows for comparative performance data that is valuable to patients and caregivers in evaluating clinician performance, and also in assisting them in making decisions about their care. The goal of MVPs is to streamline the approach to MIPS reporting and allow for a more cohesive participation experience. Next slide, please. For QCDRs that support MVPs, the QCDRs must support all measures and improvement activities that are included in MVPs that are applicable to their clinicians no later than 1 year after finalization of the MVP. So for example, MVPs that were finalized in the 2026 Physician Fee Schedule Final Rule, QCDRs must be ready to support them by January 1st, 2027. There are a couple exceptions in terms of which measures QCDRs are expected to support within the MVP. If an MVP includes several specialties, then QCDRs are only expected to support those measures that are pertinent to the specialties of their clinician. And second, QCDR measures are only required to be reported by the QCDR measure owner. A QCDR may borrow and report QCDR measures if they have the appropriate permission from the owner first. In terms of the transition to MVP reporting, current QCDR measures will be reviewed by CMS as a component of current and future MVP concepts. So some of the questions that are considered when reviewing each measure include, does the QCDR measure align with a current or future MVP topic? Does the QCDR measure complement improvement activities and cost measures? And finally, does the QCDR measure align with the goal of keeping MVP stable year over year? Next slide, please. For QCDR measures to be included in an MVP, there are a number of requirements that need to be met. For example, the QCDR measure must be fully tested and fully developed at the clinician level with the testing data to support this. This does avoid inadvertent submission, calculation, or scoring issues of a given MVP of a given measure, once implemented within the MVP. The testing data must be submitted before the end of the self-nomination period for consideration in the MVP. Some additional requirements, you are required to self-nominate as a QCDR. You must submit your measures for CMS consideration along with all the QCDR measuring testing data during the self-nomination period. And that happens from July 1st to September 1st. QCDR measures are also required to be active 1 year prior to self-nomination to be considered for inclusion within an MVP. And if you are borrowing a QCDR measure within an MVP, you must include that QCDR measure information in your self-nomination and provide written permission to borrow that measure from the measure owner. Next slide, please. Next, we'll go over some resources that are available to you as you work through measure development and self-nomination of your QCDR measures. So prior to the opening of the self-nomination period, CMS does offer QCDR measure preview calls. These calls provide QCDRs an opportunity to review their measure concepts with CMS prior to submitting them through self-nomination. The preview calls begin next Monday, February 16th, and will go through May 29th, with the last day to request a call being May 15th. They are scheduled on a first-come, first-served basis so that we can accommodate as many requests as possible. And to make a request, we ask that you please submit an email to the QCDR vendor support at gdit.com email. When you make this request, please provide multiple dates and times over a 2-week period and a list of all the names and email addresses from your QCDR that you would like to attend the call. We also ask that you submit your measure specifications at least 7 days before the scheduled call. These can be submitted either in a Word or an Excel document. Or we do have a measure template that will be emailed to you once a preview call is scheduled that you can use to submit the measure specifications. Using this template is encouraged. It's not a requirement, although it is helpful to standardize the measure information that will be discussed on the preview call. If we do not receive the specifications in time, those 7 calendar days prior, we may reschedule the meeting. We do understand that measures that you want to discuss may be earlier in their development, and for this reason we request that you provide the measure information that you do have available at that time. CMS is not expecting that every measure will be fully developed by the time of the preview call, but the more information that you provide, the better and more meaningful feedback we can provide to you. And as a reminder, on these preview calls, CMS does not make any measure decisions. The measures would still need to be submitted with your self-nomination to be considered for MIPS. Next slide, please. On this slide, we just have some links to the 2026 Physician Fee Schedule Final Rule and the associated Final Rule fact sheet for your reference. We also recommend that you utilize the Measure Management System Blueprint for measure development guidance. There's a lot of helpful information out there that may be useful for you. Next slide, please. Some additional resources listed here are the Measure Development Plan and annual reports. We also have links here to the 2026 QCDR Measure Development Handbook, the QCDR Measure Specifications, and the 2026 MIPS CQM specifications and supporting documents. Next slide, please. Again, emphasizing the move to digital quality measurement, we've included this slide with links to resources that support electronic clinical quality improvement. There are educational resources on that website, tools and key resources, and implementation related information. Next slide, please. And finally, but not least, with the transition to MVPs, we've included this slide with links to multiple MVP resources for guidance on this new reporting option. You can learn more about the implementation and transition to MVPs, and we included the Explore MVPs webpage as well. That includes details on all the currently available MVPs. Next slide, please. And with that, we've reached the end of our presentation. Just a quick reminder that the recording, transcript, and slides will be published in early March on the QPP webinar library. And I will now turn it over to Anastasia for the question and answer portion. Thank you.
Thank you, Marlene. So just some basic instructions for our question and answer session. If you would like to ask a question, we do ask that you type your question into the chat functionality within the Teams platform. We will address the questions in the order in which they are received. You may also use the raise your hand function within Teams to ask questions verbally should you wish to address your question audio-wise. In addition, I do want to just note that we will address as many questions today as possible. Of course, it looks like we have about 24 minutes left in the session. So if for some reason we do have a significant amount of questions, we will attempt to combine any duplicative questions. And on the other end of that, if we do not receive questions to fill the entire remaining time today, we will close the call early. As such, we definitely recommend that if you do have questions related to any of the content that was covered during today's session, you submit those questions early. That way we can make sure we address it. With that being said, we will go ahead and take our first question. We have a current QCDR that is currently developing a new QCDR measure for the 2027 self-nomination. This new measure is designed to expand upon the framework of QID 507 germline testing for ovarian cancer by including a broader range of cancer diagnosis to increase the clinical applicability. Of note, they also steward QID 507, and it is part of the Advancing Cancer Care MVP. Given the relationship between these two measures, we are seeking clarification on the following. Question 1. Impact on the existing quality ID. If this is expanded, QCDR measure is approved for 2027. Would CMS consider 507 redundant and subsequently remove it from the MIPS program effective 2027? And question number 2, reporting obligations. Should this QCDR formally disclose the intent to expand this measure in a response to the QCDR measures and MVPs change request email that's due April 3rd? Given QID 507 is part of the ACC MVP, or is this notification handled exclusively through self-nomination?
Thanks, Anastasia. This is Olga Kogan. We don't give specifics or final decisions until the measure specifications are reviewed and compared. We would typically look at this situation on a case-by-case basis. However, the preference is generally given to the MIPS quality measure in regards to maintaining a measure. I would encourage you to schedule a preview call so that we can further discuss the two different measures. We are scheduling preview calls from February 16th through May 29th if you haven't scheduled one yet. In regards to the second question, we would encourage you to share as much information as possible that is relevant to or has any implications on an MVP, so you can go ahead and provide that by the April 3rd deadline.
Thank you, Olga. And I do want to know, it looks like we have approximately 3 questions in queue. So if you do have questions for today's session, please make sure to get those submitted. Next question, given the increasing adoption of MVPs and their anticipated transition to mandatory status in the coming years, we would appreciate your guidance on a strategic challenge we're facing. Specifically, how should we approach MVPs with significant QCR measure dependencies when securing authorization to use measures from other QCDRs? To date, our attempts to establish collaborative partnerships with external QCDR organizations with measures by varying other specialties have been unsuccessful, and we're looking for recommendations on best practices and alternative pathways forward.
Anastasia, if you want to go ahead and read the next question as well, I can just answer them together.
Sounds good. So we did have a follow-up related to that question as well. We had another QCDR build upon the question saying, I've often wondered whether there are established criteria or guidelines that QCDRs with preparity measures must follow when responding to licensing requests for other QCDRs. Specifically, are there formal requirements governing these decisions, or do measure owners have full discretion to decline such requests?
Okay, so you are not required to support other QCDR measures. We do make a deliberate effort not to create MVPs that rely solely on QCDR measures. I would say that if you are interested in collaborating with another QCDR, certainly want to do that early in the process. If you are coming up against challenges, then we would recommend that you document your attempted collaboration and share that with us.
Thank you. Next question. Are there any QCDR or QPP measures in MIPS that are limited to group level reporting, i.e. no clinician level reporting? Asking because some new measures we are developing are more of a team sport. For example, clinicians, navigators, APP, RN, APN, genetic counselors, etc. And our clinicians don't think clinician level reporting would be appropriate.
There are a few rare measures within MIPS. However, the program is set up for clinician level reporting. We would need to discuss the details about the measure more in depth. So again, my recommendation would be to schedule a preview call and have that discussion there.
Thank you. It does look like we've got a question. We've had a few questions related to a video of this complete process. I do just want to note that the recording, a transcript, as well as the presentation will be posted on the webinar library in early March. With that being said, additionally, there is a 2026 QCDR and Qualified Registry Self-Nomination Toolkit out on the QPP Resource Library. You can certainly access that information from the 2026 perspective. There may be minimal changes from year to year. The 2027 version of that toolkit will be available typically late May, early June. And with that, I just want to double check. We do not have any additional questions in queue, and we do not have any hands raised. So not seeing anything additional. John, do you have any closing remarks for us?
Well, sure. I'd like to thank you all for showing up today and listening to the presentation. I hope that some of it was useful, if not all of it. And as was mentioned before, if you do have further questions, please reach out to those mailboxes that we've listed so that we can address those questions. I would, just like Anastasia said, I would highly recommend, if you do have questions, especially specific questions, some we can answer, some we can't. That's a matter of the rulemaking process and where the rule is in its cycle. So just understand there are limits to what we can and cannot answer at different times. But you know, if it's something related to how do I, we can probably hit it. Like I said, I'd like to thank you all for coming and wish you a happy or good afternoon.
Thank you, John, and thank you for attending our 2026 QCDR Measure Development webinar. Attendees, you may now disconnect, and panelists, please hold the line for the subconference.